My name is Dr. David Maddy from the University of Louisville School of Dentistry, and this is a continuation in a mini series of lectures that I designed for dental students that I titled Functional Occlusion and Advanced Restorative Concepts. Most of this information comes from a book written by Dr. Peter Dawson entitled Functional Occlusion from TMJ to Smile Design. There will be some references to a book from Dr. Jeff Occlusion titled Management of Temporomandibular Disorders and Occlusion, and there will be several animations that were um, created by a company called BiteFX. And whenever there is a reference to one of these three, there will be a little icon in the lower right hand corner of the slide. This is lecture number 2, and it's titled Evaluation Starts in the Back, TMJ and Centric Relation. We ended last lecture with a summation by Dr. Dawson of what he titles the inverted tripod concept. And from that, he spoke of there being two critical stopping points for jaw closure in a perfected occlusion. The posterior determinant is called centric relation, and the anterior determinant is the anterior contact of the front teeth. Think of it as a unit of the 6 anterior maxillary teeth opposing the mandibular teeth, not single teeth as this picture shows. And these are critical stopping points. And think of it as a three-legged stool, as the two condyles are to the legs and the anterior teeth is one leg. And visualize then that a three-legged stool does not wobble. It's very stable. And and this is for a perfected occlusion. Now, I like the word perfected occlusion. This is a word that Dr. Dawson uses. I like it because it implies an action. It implies something has been done. It's not a perfect occlusion. It's a perfected occlusion. So things have been improved. You'll hear, as you listen to the lectures, you'll hear the word ideal occlusion. And ideal occlusion can mean different things to different people. So for the context of this mini series, we're gonna focus on the word perfected, and we're gonna define it in a certain and specific way. So why? Why do we talk about this thing that we're calling a perfected occlusion? Because it's the most stable, it's the most protective, it's the most comfortable, and is the most predictable of all occlusions. Do patients have a perfected occlusion? Well, mostly not. So why talk about it? Why do we care if it doesn't really exist too much in its natural form? Well, the reason is because there are times you should build this into the total masticatory system. If you remember, we defined occlusion last time as being a harmonious system between the balance of the teeth and muscles in the joint. And there are times that this perfected occlusion can gain value for us. Well, when are they? Well, anytime we do complete dentures, we certainly want to be able to make this frontal bite on the denture with that condyle in a certain position. All distal extension partials. Extensive restorative procedures when they are anticipated, such as fixed removable, or implant combinations. Any signs or symptoms of occlusal instability? Any sign or symptom of dysfunction or parafunction? Hopefully during orthodontic movement, and always during splint construction. Okay, why? Because it's the most stable, it's the most protective, it's the most comfortable, and it's the most predictable of all the occlusions. And this is the reason, extensive restorative procedures, that I focused myself very early in my career on learning these types of concepts. And I started taking Dr. Dawson's lectures my first month out of dental school because I wanted to be able to do extensive restorative procedures, and I knew that I needed more knowledge in this area. So for the next 3 lectures, and the first one will start today, just in a minute, we're going to first start with the back. The evaluation starts in the back. We're going to go into the TMJ and centric relation. Then the next lecture we'll go to the front for the anterior guidance and contact. And then the easy parts is what's left in the middle. We'll talk about what we're going to define as posterior non-interfering contact. So today, we're going to begin with the conversation of evaluation starts in the back. Centric relation, as stated by Dr. Dawson, he says that the single most important factor in diagnosis and treatment of occlusal problems, an understanding of centric relation would do more for achieving predictable treatment success than all other factors combined. For review, remember that centric relation has nothing to do with teeth. It's a condyle-only position. And that MI, or MIP, as one can also use, has nothing to do with the condyle. It's only teeth position. Orthopedic surgeons treat joints, mostly hips and knees. Hand surgeons treat joints, mostly knuckles and fingers. Rheumatologists treat joints throughout the whole body. Chiropractors treat joints, mostly back and neck. But the temporomandibular joint belongs to us, and I believe is the most complex of all. It allows us to speak, smile, eat, laugh, yawn, and aids in breathing. And so it's ours, and we need to know about it, and it's important that we understand it in great depth. So we're going to talk about that. We're going to talk about the understanding of a healthy temporomandibular joint. A little bit of review of the anatomy. Of course, we have the condyle. We have the articular eminence. Notice its steepness. The disc is designed for heavy, enormous load. We have the posterior ligament that tethers the disc to the back neck of the condyle. And we have synovial nourishment between the upper and the lower chamber of the disc. And we have the lateral pterygoid muscle, which attaches to the head of the condyle. Then there are the retrodiscal tissues, which is immediately posterior to the condylar head. Let's look at the disc a little bit more. And remember that it's designed for enormous load. It's made of fiber cartilage. It's biconcave and elliptical in shape. It provides a low friction articulation surfaces within the joint. The biconcave shape provides a smooth articulation between the two incongruent surfaces of the condyle and the articular eminence. So what that's saying is that as that condyle goes forward, and this movement is called translation, there is intimate contact between the condyle and the articular eminence because of the disc maintains the shape. The biconcave shape has a self-centering design. From the side, we have the anterior band. We have the intermediate zone, which is the thinnest. It's only about 1 millimeter thick. And we have the posterior band. And notice that it is the thickest. And this part of the disc becomes more significant later on when we speak of dysfunction. The superior joint cavity is where the translation occurs, and the inferior joint cavity is where the rotation occurs. So this is a review. Look at it from the side. We have the medial region, we have the center region, and we have the lateral region of the disc. Going further into the components, if we look at the disc, we'll see that there is a medial disc ligament and a lateral disc ligament, and these attach the disc to the medial and lateral poles, tethering them down on the sides. And notice that because it's tethered on each side, it allows for a rotational movement of the disc over the top of the condyle. Think of it as a bucket handle. You know how a bucket handle can rotate around? Let's look at this video here to show you. I want you to notice that when the condyle is in the most superior, or in this case, posterior position, that disc is on the anterior section of the condyle, but as such as we see right now, kind of towards the anterior. But then when translation occurs, that disc rotates with this bucket handle effect more towards the superior. So we need to be able to have a rotational movement of the disc in order for translation to occur. Other components, in the back of the disc, there's another ligament. It's called the posterior ligament. And this disc is tethered to the back of the condyle by an inelastic band of collagen fibers. This prevents the disc from rotating too far forward, and that becomes an issue again later in dysfunction. It limits the forward movement. It must be stretched or torn to permit any forward displacement. So it is a limiting factor. Remember, ligaments limit, and that posterior ligament keeps that disc from going further than is physiologically important. Behind, we have these things called the superior elastic stratum. These are elastic fibers that bind the disc to the temporal bone and maintain constant tension on the disc towards the distal. Think about it as like a rubber band that's always tugging on the posterior section of the disc. We have the arterial venous shunt. And so when that condyle goes forward, which we call translation, or it's a protrusive movement, but when that occurs, they can't have a void, and so the area, the anatomical area behind the condyle then fills up with a venous plexus of blood. And when it goes back into the most superior or distal position, then that venous plexus expresses the blood out. It fills the opening that would occur. And we have the temporal mandibular ligament. It attaches to the base of the skull to around the distal back part of the condyle. And what it is when that condyle is in centric relation, it is actually lax. And when rotation occurs, then that ligament reaches its limit and it forces translation. And I mention this at this point because there might be some confusion that this ligament positions final position of centric relation. And we're saying that's not true. It is a limiting factor in rotation, then causing translation. So the next question is, why do we translate? And if we didn't translate, things would be easier and less complex, and there'd be less potential for dysfunction and or breakdown. So, but why do you think we would translate? You know, think about that for a minute as you ponder. And let me show you, this is an alligator. So as you're thinking, I'm going to ask you, do you think an alligator translates? You see they've got a completely different kind of condyle rotational movement looking in the base of the skull. Well, I'm going to tell you that the alligator doesn't translate. See, the alligator doesn't need to translate, but humans do. Or actually anything, or any animal that has an upright vertical stance and a perpendicular head position needs to translate. The reason is because as the further you rotate, then the closer that comes to impingement upon breathing. The translation allows a little bit of forward movement in order to have a system that doesn't block airway. It also gives maybe greater functional movement in borders as well. Often when we show the disc, we do a cross-sectional viewing, but I wanted you to see that this is really what it looks like from a three-dimensional standpoint. We have our disc, we have our retrodiscal tissue, and our posterior ligament. And so think of this as your visualization, not a cross-sectional view. An intact disc will not displace or get out of alignment. And so I'm introducing this thought to you now because this becomes more important in dysfunction. When we talk about alignment, let's talk about it maybe being too far forward. It's firmly tethered in the back by the posterior ligament that limits its forward movement. And the only tensive force that attaches to the disc is the superior lateral pterygoid muscle. Disc alignment is related to muscle. Let's have a closer look. If we do a cross section, we'll see that lateral pterygoid has a superior head and an inferior head. I'm going to show you now a video that's going to do an overall visualization of the opening and closing in a healthy TMJ. So we have our opener muscles, the digastrics, which start by rotation. And then we have the positioner muscles, the two heads of the lateral pterygoid that position the condyle and the disc itself. And then we have the closers, the temporalis, the masseter, and the medial pterygoid. And these muscles are what create great force and function and chewing. So as we walk through this video, we're going to start with the rotation from the digastrics, and then the positioner. The lateral pterygoid then protrudes and causes the jaw to go forward, and then the heavy masseter, temporalis, and medial pterygoid, which causes strong chewing. We'll do a little bit of a close-up now, and what we're going to focus on for a little bit now is that lateral pterygoid. And notice as this opening and closing occurs that it's really broken into the two heads, and one contracts and then the other one is relaxed, and vice versa. Lateral pterygoid when opening, going to view that in detail at this point. And notice that when the condyle is in the most superior position, as the top picture shows, the position of the disc is more to the anterior of the head of the condyle, and that when that condyle is moved forward or protruded or translated, the position of the disc is more towards the head, the bucket handle effect that we talked about previously. So let's see how this works. So as we start to protrude, the inferior head of the lateral pterygoid contracts and causes forward movement. And then the superior head relaxes because remember that disc has to get to the top of the condyle. In the process, the elastic fibers in the posterior section of the disc pull as like a rubber band would, and they positioned that disc towards the top. When we're closing, again, we're starting on the top. That condyle, the disc is on the top, and it needs to end up towards the anterior. And in order for that to happen, the inferior head of the lateral pterygoid has to relax for the condyle to go back, and the superior head needs to contract in order to reposition the disc towards the anterior against the pull of the elastic fibers. How do we know that? A gentleman named Parker Mahan, a researcher who was at Case Western and University of Florida, did research with little probes in the muscle, and he used dental students to record this physiologic complexity. Now I'm going to let Doug Brown, the CEO of BiteFX, walk you through this in an animation. And this animation was designed for dentists to show their patients. So he'll use some basic words, but you'll get the idea of this complexity of this lateral pterygoid. And anytime you see an animation from BiteFX, notice that those red lines, when those red lines line up on the top of the condyle in the glenoid fossa, that means that condyle is in the most superior position, what we call centric relation.
Before explaining why malocclusion can affect your jaw joint, we should first introduce you to your temporomandibular joint, or TMJ. First, here's how your jaw works. You have a muscle under your jaw that pulls it down to open. Then, to open really wide, your jaw actually comes out of its socket and is pulled forward by another muscle. To close, these muscles relax, and your strong closing muscles go into tension and bring your teeth together. Now let's take a closer look at the joint. The upper part of your jaw, called the condyle, fits into a socket in your skull, called the fossa. Between the condyle and the fossa is a disc called the TMJ disc, shown here in orange, which is as tough as cowhide. The disc tracks with the condyle as it moves forwards and backwards. At the back of the disc is soft spongy tissue, shown in yellow, which expands and contracts to fill the void as the condyle moves in and out of the fossa. A lateral muscle tenses to pull the jaw forwards, and its partner tenses as the jaw closes to help hold the TMJ disc in place. The vertical lines in these animations are placed to show where the jaw should be when it is properly seated. So you can see that there are several elements that make up the jaw joint, and they need to work in harmony for the healthy functioning of the jaw.
The complexity of all these movements are controlled from a mechanico-receptive standpoint, with the periodontal ligament being a source of innervation. It travels up to the CNS, comes back to the muscles for the coordinated activity, and this is all subconscious and not something that we even realize what's going on. So we're going to shift gears for a second, and we're going to change from looking at the healthy physiology of the lateral pterygoid in the TMJ, and we're going to now speak of condylar position, and particularly with reference to what Dr. Dawson was talking about in the inverted tripod concept, in that what is that condylar position and where is that critical stopping point. So my question to ask you is, during chewing, what direction does the condyle go in function? Now remember that the eminence has a steep angle and that it's very slippery because of the synovial fluid, like think of it oily, and that the elevator muscles are distal to the teeth. So if we look at this picture here, we'll see that there's a bolus of food, say in the second molar area, and we're going to do some heavy squeezing in order to chew up that big piece of meat. And that condyle could be anywhere within the range of its translation positions that it can go into. And so then the next question is, what is the direction of the muscular force? If we look at these pictures here, we see that the elevator muscles all pretty much go into an up pull and some towards the anterior. And so we chew on the second molar with the food. The muscles are behind with heavy contractive force. And so what direction does the condyle go? Well, if we look at this picture here, the dotted line is somewhere down the eminence, and when squeezing occurs, that condyle will pivot around that food until it stops into the most superior position. So the question is, what stops that superior movement of the condyle? Then, in order to understand that to the level that I believe is significant, we're going to talk a little bit about the pivoting axis. You'll notice that the ramus and the condylar head are at a 90-degree angle to each other. And that if we get a little bit of a closer look and we zoom in a little more, like right here, we'll see that initially upon opening, as you remember, there can be a pure rotation for 20 to 25 millimeters, which is average, and it pivots around an axis. And so if we draw a line through that pivoting axis, we'll see that that line goes through the medial pole of the condyle. Notice that the lateral pole is outside that pivoting axis. So if we look at this diagram here, we'll see that the closer you are towards the medial, then the more pure rotation, and that lateral pole tends to have more of a translation, circular wobble, let's say. If we look at this is a good example. This is an articulator that was developed by an orthodontist from the United Kingdom, and it was designed to copy and mimic mandibular movement. And of course, the articulators we use, we lift the upper for rotation, but this was designed for the mandible or the lower member to actually rotate. If we look right here, you're looking at the lateral pole. And now I'm going to push down on a little video, and we're going to see what happens to that lateral pole as it rotates around the axis of the medial pole. We'll see when we push it down. Notice that lateral pole kind of moves. It wobbles. So the thought is this translation of this lateral pole while the medial pole rotates provides a sort of a windshield wiper effect for the spreading of synovial fluid back and forth over the entire surface of the condyle and bearing surfaces of the disc. Let's look at it from a perspective of the bite effects animations. Rotate this around. We have our rotational axis as we've drawn through the medial pole. And we'll see we'll get first a pure rotation around the medial pole. And then also when we start to translate, we'll see that the force of the bearing travels from the medial all the way out to the lateral side. We see in this animation we're adding in the muscles of the superior and the inferior head of the lateral pterygoid as translation occurs. X, the axis of rotation around the medial pole. So we still haven't answered the question, what stops that condyle? Where is the pivot point? Well, if we look at this skull, and this is a mandible and a skull that I took a picture of. I wanted you to see the relationship of the two. Of course, there's a disc there in real life. And so the question is, what happens if we have a severe blunt force to the lower mandible? Like we had a car wreck, or maybe we get punched. What does that condyle do? Well, you can see from the picture, it breaks. So something is stopping that condyle in such a firm way that the actual condylar head breaks. And this is the most common occurrence of a breakage, as this picture illustrates. If, however, we look at the top of the condyle, and then we look at the corresponding bone, we see that that area there is pretty thin. And if we take that skull and hold up to light, we'll see that the top of the condyle has a very thin opposing bony area. And so the question is then, if we have a force blunt, like we're hit hard, or we have a trauma to the lower jaw, and something is strong enough to break that condyle, we can see that it's probably not the top of the glenoid fossa, because it looks to me like if that were to occur, then maybe that condyle will go through that thin area and go into the base of the brain, which really doesn't happen. So there's an actual physical stop that is strong enough to break it. Now, ligaments can't withstand that. You put heavy force, a blunt force on a ligament, it'll stretch or tear. It's not strong enough for the actual breakage. Of course, muscle can't hold it strong enough to break too. So there has to be something more secure than that. So let's look at the medial head of the condyle against the medial wall of the glenoid fossa. And so that is the actual contact, as the picture on the left shows. Of course, there's a disc there. And so we can say that the condyle is really braced by bone with a disc between. That final and superior stop is bone to bone. Now we have different definitions that I should cover at this point of centric relation. And the most common here is that it is the most anterior superior position, defined as centric relations is the mandibular jaw position in which the head of the condyle is situated as far anteriorly and superiorly as it is possible, as it possibly can within the mandibular fossa and or glenoid fossa. And so it would kind of look like this. This is out of Dr. Okeson's book, and you can see that that at its most superior position, he draws this as though there's a little bit of a horizontal component. But in my experience and all the treatment and the clinical observations I've had, I've never been able to detect a horizontal component to the most superior position. And of course, articulators don't allow that in any kind of adjustments. And so, to me, a simpler way is to think of it as the way that Dr. Dawson describes it, that it's just superior only. And he thinks of it as like an apex of a triangle. But regardless, they're both superior, so there's really no incompatibility with their definitions. So Dr. Dawson defines it as centric relation is a relationship of the mandible to the maxilla when the aligned condyle disc assemblies are in the most superior position against the eminition, irrespective of vertical dimension or tooth position. And also he states that there are 5 criteria that must be fulfilled in order for centric relation position to be. First, the disc is properly aligned on both condyles. Second, the condyle disc assemblies are at the highest point possible against the posterior slopes of the eminition. The medial pole of each condyle disc assembly is braced by bone. The inferior lateral pterygoid muscles have released contraction and are passive. And the TMJs can accept firm compressive loading with no signs of tenderness or tension. And we call that load testing, and we'll talk about that a little bit as this class develops. The key, though, is properly aligned in the highest point, braced by bone, muscles released, and able to accept firm compressive loading. Centric relation is physiologically correct. It's biomechanically correct, meaning you can load it without pain. You should be able to chew heavy things and not have pain up into the jaw joint area. It's precisely repeatable. It's always comfortable. It's learnable, and it's the only jaw relationship that permits an interference-free occlusion. How do we clinically locate? Well, there's lots of different clinical techniques out there, but what is taught by the Dawson Academy, and it tends to be, in my hands, the most predictable, something called bimanual manipulation. And it's just a technique for actually just allowing the condyle to go where it wants to, which is in centric relation. That lateral pterygoid doesn't want to stay contracted. Or another thing you can do is use any method that allows the inferior belly of the lateral pterygoid to relax. And so there's things like anterior deprogrammers, like what's showing here is a Lucid-Jig or maybe even a cotton roll. But the key is for that lateral pterygoid to relax, to allow that condyle to go into the most superior position. And we use those things to break what are called muscle engrams. And we'll come to that a little bit later when we go into dysfunction. So the key points today, what I want you to remember out of all these details is that lateral pterygoid has an antagonistic and a protagonistic role. It has a complexity to it. And this, again, will become more apparent when we look at dysfunction. And that condyle is stopped by contact between the medial pole of the head of the condyle and the medial wall of the glenoid fossa. It's braced by bone. It has a critical stopping point, as we started our lecture when we were defining parameters of a perfected occlusion. But you're going to see we're going to have a dilemma, because often when that condyle is in that most superior position and pure rotation occurs, it's very common that the back teeth somewhere might hit a little first, and if we stop there, we call that centric occlusion. But in order for the teeth to make full contact into what we call MIP, or a maximum intercuspation, that condyle has to come down that eminence just a little bit, and that lateral pterygoid has to bring it down into that contact. And that's commonly found. It's a dilemma that will develop as time goes. But if you were to look at somebody and you look at their anterior relationship and you just have their teeth closed and MIP, it looks good. The teeth look like they touch. But if, however, you stop them and look at it when the first contact occurs where the condyle is seated, then often we have an opening in the front, like the picture on the left. Of course, this is a very large discrepancy. We call it a discrepancy. And this is what's most common. Little tiny discrepancies, anterior teeth can't quite touch. And so let's say it this way. See if you can follow at this point. Since CO and MI, or MIP is the same thing, are not the same, the condyle cannot stay in CR, so that the condyle must translate down the eminence. Again, this will be a topic that we'll go into detail more as this class develops. So what do we do next? Well, next time we're going to talk about the front part of the inverted tripod. We're going to talk about the anterior contact and the guidance.